Do you want to introduce yourself?
You can introduce us to the shorter. No, we don't.
Yeah. Then you take over the control. Yeah, I like that. Hi everyone. I'm gonna do this in English. My name is Ragnar, and on behalf of the team involved in this meeting, I would like to introduce the main speakers here today. But first of all, I would like to tell you how it all started. It started like that. A few nurses that heard Baruch and Piet speak in Copenhagen in 2022. After that, Steinunn Snæbjörnsdóttir, anesthesia nurse, who's here today, contacted them and asked them to speak here in Iceland, which they did. And we had an interdisciplinary conference day at the Erðagreining, which was an eye-opener for many of us. Since then, we've had approximately 20 nurses from Landspítali Hospital attend PROSA, a conference in Maastricht. This has changed the way we treat children, and most importantly, the way we think about the process and their right to enjoy the benefit of the doubt. Dr. Baruch Krauss is a senior associate physician in pediatrics at Boston Children's Hospital in New York and an associate professor at Harvard Medical School. Dr. Piet Leroy, he was trying to teach me this earlier, is a senior consultant in pediatric critical care and a director of the pediatric procedural sedation unit at Maastricht University. He's a professor in procedural sedation and analgesia in children at Maastricht University. So please welcome Dr. Piet Leroy and Dr. Baruch Krauss.
Can you hear us? Yes, great.
And can you turn the lights up?
Yes, can someone switch the light on when we show?
If you want to walk around.
Oh yes, we do. We do. We can't.
Do we need it? Can you hear me? No. Yes. No?
No? And you're streaming this, so maybe for the streaming it's also better to have a microphone. Okay, is there someone who can switch on the light for a while? Because we were kindly introduced. Thank you for the introduction.
Oh, here's another one.
Yeah, there's another one. Is this one working? No?
This is for the stream.
For the stream, that's for the streaming.
Yeah, it's only for the streaming.
Then I'll put it on for the streaming, so for the people at home, wherever in the world they might be, I'll put it here. But I stay close to the microphone. Thank you for having us again here. It was
No, please leave the lights on.
sweet.
Please,
None, and
completely on.
yes, and once we show our yes, because we want to see you.
Yeah.
Actually, you came to see us, but we came to see you. Thank you for the kind introduction. It was, I think, late August, early September 2023 when we came here for the first time. And so we're very happy we are back. We are actually here for the conference in about the Scandinavian Conference on Anesthesiology and Intensive Care Medicine, which is taking place in Reykjavik tomorrow and the days after. We are lecturing there tomorrow. And you contacted us with a question as we are here, could we join you again? And here we are. So thank you for having us. Before we start, sorry for the microphone. Before we start, you know who we are, but who are you? Who is working in this hospital here? Is everyone working in this hospital? So some people are working, who is not working in this hospital? Can you say where you're working? Health clinic? Someone else not working in this hospital? Yeah?
Other part of this hospital.
Other part of this hospital? Okay, but not the pediatric hospital? No? And someone else who's not? Health clinic? Okay, thank you. Who is a nurse here? Who is a doctor? A doctor? And those doctors, who is a pediatrician? A few pediatricians, anesthesiologists maybe? Surgery, some surgical thing? Resident in surgery, great to have you here. Who is a psychologist? 2 psychologists. Child life specialist or somebody with a more teaching background, maybe? No? Have you mentioned everyone now? Who's still? Okay. Thank you, so that we know a bit who you are. Actually, what we prepared is a very small slide set to introduce the topic again, to refresh the topic. But actually, the biggest part of this meeting is actually intended to discuss cases again with you, challenging things that you meet. So therefore, before we start, we would actually like to know, what do you want to learn from us? And I remember when we came to Iceland for the very first time, we were warned that we should never try something interactively with people from Iceland. That was the warning. Don't try, don't try. But we did, and actually the symposium was a full afternoon of interactivity, those who were there with us. So then you learn that we are very safe. We just are welcoming, but we just want to know what you want to learn. Maybe some people, maybe you don't want to learn anything and want to go home as quickly as possible. That's also a good ambition in life. But can you mention a few things? What should we talk about? Yes?
Yeah, I'm wondering if I can learn more about the different types of anesthesia, when to use it, which kits, which procedures, how do you choose it?
Do you mean to choose between anesthesia and sedation, for example? Okay, that's a great question. So when is there more an option to choose for sedation, and when is there more, it's better to choose for anesthesia? That's your question. Do you have an anesthesia background? No?
We just use sedation now.
Okay, yeah. What kind of sedation do you use?
Midazolam,
Midazolam,
yeah, clonidine,
Dextor. You use nitrous oxide as well? You don't have laughing gas here in Iceland?
Yeah.
That's laughing gas. That's I mean in the hospital. I mean the use of laughing gas in the hospital. Wherever you might use it outside the hospital, that's not the topic of this meeting. So the choice between sedation and anesthesia. Help us remember that. Other questions, other things that we should discuss.
Sticks and needles.
Again?
Sticks and needles. Sticks and needles.
Sticks and needles. As a general topic, sticks and needles.
Even to children that don't want them.
Children who don't want them. Injection phobia. Okay, sticks and needles. It could be the name of a workshop for acupuncture. Sticks and needles. So welcome to our sticks and needles workshop. Great. Okay, sticks and needles, needle phobia. You're the psychologist. We know now that you're the psychologist. Do you see often children with needle phobia? Yeah. Okay, it's good. We'll try to focus on that. Other things that we should discuss.
To pick up that maybe the psychological thing of trying to do any examinations with an unwilling child.
So the unwilling child, how to approach the unwilling child. Baruch, that's a question probably for you. How to approach the unwilling child? Okay. The unwilling child. That's an interesting concept, the unwilling child. But try to focus on that as well. Other topics? Your next holiday destination in Europe could be a topic, whatever. No? Any other thing? Okay. Then I suggest that we start first with our small introductory lecture. It's just putting some things on the line, and then we'll dive into the cases. Yeah?
Can I add one thing? Distinguishing between needle phobia and oppositional defiant disorder.
And?
And, you know, when they're just being in opposition.
Yeah, just...
And where you don't
Yeah,
do it.
yeah.
And it's not
Well,
that they're afraid of the needle, but it's
just they just don't want to collaborate with you. Yeah. Yeah, so the question is here, how to differentiate a child that is having needle phobia, so really anxious for needles or medical procedures, and how to differentiate that with children who are just not collaborating, they are spoiled kids, not well educated. You don't have these kids in Iceland? You do, so the more the educational challenge. Okay, great question. We are both experienced fathers, so we can speak from our own experience here. Okay, great. The autistic child, autistic children and children with autism is a huge challenge. You mentioned the PROSA conference. I'll speak a little bit about it. But next session in September, we'll have a whole session on children with autism because it's such a challenging topic. Okay, Thank you. Shall we, have you explained the button B already on the, look, here's B. You see, it's, if you want the black screen, just put the B of black, there's the black screen. And if you more desire a white screen, just put on the W of white and you have a white screen, you see. So you have learned already something now. It's the beginning of learning, isn't it? The R is not going to give you a red screen, so it's only white and black. That's the only options. So here we are. Can you properly see the slide, or should we? You can see it, so far so good? Okay. So what we're talking about is trauma-free medical care in children. That's the mission that we shared with you 3 years ago, and that you have moved so much further now based on what we've learned. It's impressive what you've been doing in the last couple of years. So actually, just going back to what we did 3 years ago is we came here and actually we were invited to, because some of you heard us, and then we said, no, we are not going to come unless you do something actively yourself. So we had the symposium, but we also had the visits in the hospitals and different departments, and it created a whole atmosphere of collaboration. And I think we succeeded together in creating that common vision with you, that before you start solving all these different challenges, you first need a common vision. First, be sure that you collaboratively think it's important and that you can define some standards of care. That's the first step. And all these issues that you raised are very important challenges, but it all starts with a common vision, with a common language, with a common... and what we did is, what we want to do now is shortly rephrase a little bit and reconsider the impact of procedural distress in children, to understand what procedural distress is all about, and to suggest this multimodal approach for procedural comfort. And when we have time enough, we can move also to the framework of establishing trust with children. So these were the topics of the symposium 3 years ago, and we just going to summarize them shortly in the coming 20 minutes. So this is us. That's we, doing the best we can for the children we care for, you see? That's what we see on our websites of our hospitals. Can you see the pictures properly? Maybe we should dim the light a little bit later. Can we? Yeah. And then, yeah, that's great already. That's great already. So you see, we do a lot of good things for children. And of course, they have to collaborate with us. They have to understand what we are doing and what we are aiming for. But we know that this gold medal of pediatric care has a backside, and the backside is all the procedures we do every day again. And I know you know, and that's what we increasingly realize is that all these medical procedures, they come with pain and fear. And when children, especially young children, when they don't understand why you do the procedure, they will resist, they will not collaborate. You can explain to a 3-year-old that you need a CRP in the blood because you want to check for their infection, but that's not why they would collaborate. And so very quickly we move on to use restraint. We hold down children, and holding children down creates more pain and fear. And when you speak about needle phobia, if you go back in the history of a child, you will always find these distressing moments. Usually the combination of not understanding, pain, fear, and then together with the feeling of being forced or being abandoned, not being seen, not being heard. And we often say as professionals, oh, it just takes a minute, but even these very short moments, they are directly planted in the stress memory of children. And the younger they are, the more vulnerable they are. And that's also a new insight we increasingly get, is the younger children are, the more delicate they are, the more susceptible they are for creating negative memory. And that's not what we used to think. We used to think that the young children, they will forget, but the younger they are, the more vulnerable they are. And it's even so that we know now that in neonates and premature neonates, each pain stimulus, each stress stimulus is directly imprinted in the brain and causes even brain damage. So you see, the younger you are, the more vulnerable you are. And most needle phobia starts actually at a young age, even needle phobia in adults. So yes, this restraint, this pain and fear, it creates adverse medical outcomes. It creates traumatic memories, sometimes even post-traumatic stress. But what we consider as the most important challenge is that these children start losing their trust in us. They don't want to come anymore. They don't want to collaborate. And the real problem is that we all work in healthcare, but we create each other problem. When you treat a child for the first time and you do it the wrong way, maybe you will not see the child anymore, but then the child will come back to the dentist or for a vaccination or for an emergency call or whatever, and then you cause the problem for your colleagues. So unless we collaboratively and consistently do the same approach, we'll still have to, we'll go on facing this problem. If you go into literature, you can divide children more or less in 3 groups. So more or less 1/3 of the children are easygoing. Like at the left of these are vaccination pictures. I collect vaccination pictures. So that's one of my guilty pleasures. So if you have nice vaccination pictures here in Iceland, please send them to me. My email address is therefore on the bottom of each slide because I have a huge collection of vaccination pictures. The reason why I use them is that they're often they're just published in journals, in news. When it's about vaccination, usually they put pictures of children and you see the whole response of stress. Look, the boys at the left, these belong to the 1/3 of children that just are easily going. These are the easy patient, the good patient. They usually have the good parents and the good educational mood. That's, you know, that feeling. We love these patients. We are so welcoming for those patients. And look, the boy at the left, he's saying, come on, give me some extra shots. I'm here for vaccination. Give me 5, 10, whatever. I'll take even a needle without a vaccination. They are just, or the boy on the top left, he has his own strategy to cope with. Some children are spontaneously coping with it because they learn something. Here in the middle, these are the tricky ones. They are collaborating, but they have a higher stress response. And you see the girl at the top, she's managing herself, but you know, if maybe the 3rd needle wouldn't be successful anymore. You see, so these kids need help. And the boy here, good for him that he hadn't forgot his hat at home. He has his own self-hypnosis, you see, so, wow. That's not an accident, I hope? Or is it just the soup that is going around? Is this, no, okay. But here at the right, here you see these children that look just for vaccination. It's only this minor, simple thing. But look here, the stress response here, these 1/3 of the children are just really frightened when they come to a hospital. And this is what you see in standard population. You can imagine when children have an experience in the hospital, when they have a chronic disease, that they shift to this side. The more they have negative experience, the more they will be here. If you see children with diabetes, for example, or a chronic condition, the chance is higher that they will be at this side. And of course, then we have these vulnerable populations. We have some children that are just very susceptible for any traumatic event. Of course, the newborn baby at the left, I mentioned. Here in the middle, it comes from a video that we've recently taken from a girl with Down syndrome that needed an eye examination. And she needed to accept just the glasses to be able to check her vision. It took 3/4 of an hour to make her tolerate the glasses. This boy with spasticity, you can imagine if you just take his arm and start puncturing, that will create pain already, even without negative experience before. And of course, a boy like him probably has a lot of medical experience already, so he's prone for negative responses. The boy at the left with a suspicion of the autism, how to approach these kids. And this is a boy with hemophilia. And I recently just followed a child with hemophilia, a newly diagnosed boy of 15 months old who was referred to our hospital. And we just followed up how many needle procedures he underwent in the first 6 months after diagnosis. Can you just guess how many needle procedures in a newly diagnosed child with hemophilia, which is a clotting disease, it's a coagulation disease. And so after 6 months, how many needle procedures do you think he has had? 30. What? 30? 100? We counted all efforts, it was 85. 85, and the majority of those were done under EMLA, but about 15-20% was done without EMLA. that was enough to cause severe trauma at the age of 15 months. And his disease is a lifelong condition. So you see, these are high-risk patients. Now, what is the answer to this? That's the whole model of procedural comfort care, what we call procedural comfort care. And procedural comfort care, this is on our website also in the Netherlands. This summarizes everything. This is procedural comfort care. What's on the slide? You see the combination of two things. You see on the bottom there is a procedure taking place. You can see it at the left. But look, the boy is not interested in the procedure. He is completely in a task. He's completely in something else, which he is able to do. This boy is too young to understand blood sampling. In an older boy, it could be the case that he's actually collaborating with the blood sampling, that he's actually engaged in the blood sampling, but this boy is too young for that. So these teams decided to train him in bubble blowing, and he's really challenged in bubble blowing. So this is not just bubble blowing. The nurse on the top left there, she's really an expert in bubble blowing. She's challenging the boy in, can you blow 2 bubbles? Can you blow 1 big bubble? Can you blow the bubble now so that it flies over your feet? So there's a whole interaction going on here. And you see in between, oh yes, by the way, there is a blood sample. So you see, it's a completely different approach. Instead of thinking about the distraction technique when the procedure is scheduled, no, this boy is scheduled for an interactive play, and by the way, there is a medical procedure done. And you see, by the way, this is his mother's hand, you see? Showing how much trust this boy has in the medical team. He's closer to the nurses than to his mother. So that's, for us, this video, it's part of a video, is actually summarizing the whole concept.
And you should say also that
Yeah.
there is a perfect example. This is a very complicated, you think about it, cognitive and motor task for the child. And what he's doing is he's getting a sense of mastery. So it's very rewarding, the experience for him. He's learning in the process.
Yeah. Yeah. It's very good that you mentioned that, because the whole philosophy is not about just making this a pleasant moment. Of course, that's the first goal, making it a pleasant moment so that the child will collaborate and that the blood sampling can be done. But there is a whole learning philosophy behind this. Children are learning creatures. That's what they do spontaneously. Everyone who has a young child will see that they are learning. Anything you do with them is learning. So if you learn them, if you teach them that this will hurt and will be a fight, then that's what they will learn. That's what they will become good in fighting and resisting. This is about capacity, agency, responsibility, learning to collaborate. This boy in this unit comes every month for this blood sampling. He has a chronic disease, and he doesn't come for the blood sampling. He comes for meeting this team, for bubble blowing together, and then, by the way, oh yes, we still have to do a blood sample. So you see, the whole goal is learning. And once he's old enough, he will have learned that he can trust healthcare professionals. And then he will be old enough to understand that this blood sample is important for his condition. And then you have learned that this can be pain and stress-free, and then collaboration goes automatically. This boy, this picture was taken about 7, 8 years ago. He's older now, and he's now just coming here, just puncture me. I put on EMLA at home, and I'm coming for the blood sampling. Now he's wise and smart enough to understand why the blood sampling is needed. Do you see the learning philosophy? And that's why you have to share the same vision. Because if you share the vision that's about learning, but you think it's about blood, then you don't have the same vision. And that's extremely important. So what's procedural comfort care? It's actually, we consider comfort and medical treatment as 2 sides of the same coin. Equally important, equally essential. And that's not an easy one. It's just easy to write it down, but to consider both things equally important at any time is a huge challenge. So when a child comes in for the first time, referred for the suspicion of a certain disease, we all start thinking medically. That's great, keep on doing that, but at the same time thinking, okay, we need to do something. How can we do it in a way that comfort is guaranteed from the very first beginning? And of course, what to do in emergency cases when there is no time, etc. These are the real practical challenges.
And in every experience, one should be thinking, in every encounter, I want you to be thinking, what experience am I creating for the child through this?
Yeah. We'll come back on that. It's very important because what you leave behind, what kind of memory you create for the next time. We'll come back on that in a minute. So procedural comfort care ensures that, of course, that the procedure is successfully and comfortably. That's the first goal, of course. That's, of course, where the child is for. We need the blood sample or the CT scan or the nasogastric tube or whatever procedure we're talking about. It needs to be successfully and comfortably. But there is a second goal. The second goal is that children and parents preserve their trust in their care provider, and in their own ability to cope. It's all about trust. And that's why the quote behind what we speak about is always, it's not about from fear to no fear or from pain to no pain. It's about from fear to trust. Trust is in the core of the goal. How can we do work in such a way that children trust us? Not only because we are good doctors and choose the right antibiotic, but that they see a human approach, that they are respected, that they are engaged, that they are seen.
And so much of what we'll be talking about is how do you demonstrate to the child that you are trustworthy?
Yeah, yeah. That's the great question. So just walk around your own department and try to imagine how a child would see that department. And is what the child sees trustworthy? Does it contain the information so that it makes children trust? Do we behave that way? And what when it comes to a medical procedure? And then there's a third goal of procedural comfort care. That's the learning. In young children, you have to invest quite some time to do this good in the proper way. But it's about learning. Children and their parents become competent and confident in facing their medical challenges. That's the ultimate goal. Just like when a child comes with diabetes, you want that the sugar is well controlled so that you know that these children will grow up in a healthy way and will not develop cardiovascular complications when they are adults. That's the long-term goal we have. A child with cystic fibrosis, we have a whole management trying to keep them as healthy as possible for the long term. A child after a car accident, the whole treatment is focusing to preserve their future. Similarly to that, this is about maintaining their competency and their confidence so that they actually learn from us how to behave and collaborate with us. So it's more than just the procedure on its own. Every child you see, don't think about the moment itself, but think about the journey the child is in from baby to adult and how you can make the difference at that particular point. Are there questions about this? Because that's the ideal world. Any question about this? Yeah, please.
Are there cases where you can't do anything, like patients that are whatever effort you put,
Yeah.
how much you try, they
Yeah.
are always ready?
Yeah, absolutely.
Repeat the question.
So are there patients where this is impossible? That's actually what you ask, where it's so challenging. Oh, yes, there are. There are children who are, for example, have such big mental problems that actually even taking care of them at home is a stressing event already. It's like brushing their teeth, for example, or taking care of them. So actually, you should always try to do the best you can for that particular child in that particular situation. Another example is a child coming in with a life-threatening bleeding in a car accident. If the child resists, that's not the moment for learning, of course. You're saving a life, you see. Or children who are very traumatized, sometimes it has become impossible to regain their trust. Fortunately, we know that there are more and more psychological techniques, methods to heal children from their trauma. But in the meantime, the medical procedures before the trauma has been recovered fully, it's a huge challenge. And then bringing me back to your question about anesthesia versus sedation. Usually we use sedation for small procedures, things that happen on the pediatric ward. And anesthesia is for major procedures. You agree, like for a central venous line, for example, or bone marrow punctures, or organ biopsies. In many hospitals, this is done under anesthesia or deep sedation. So that's how we usually look at this from a procedural perspective. But sometimes children who are extremely frightened for simple procedures might benefit from anesthesia for simple procedures. And let me tell you one simple anecdote to show that. A few years ago, a child was referred to us, to our unit, 4 years old, and she was suffering from premature puberty. Do you know what I mean? So that's an abnormal hormonal condition where puberty starts at the age of 4 or 5 years old. That's not normal. So the treatment of that disease is regular injections of hormones, where you actually just put down the whole puberty, and you do that from the age of 4 or 5 years up to, let's say, 11, 12 years when you accept that puberty can start. So that's a treatment of, let's say, 8 years in this girl. Every 6 to 8 weeks, an intramuscular injection. And maybe those who have given those injections, it's the medication is like glue. So you take it out of the package and it starts like coagulating immediately, so there is no time to put it carefully somewhere. You need a big needle, otherwise you can't get it through. So once you have put it in the syringe, you have to inject it. You see it a little bit how it's... So by our endocrinologist, the child was diagnosed, and then she was referred to the general practitioner outside the hospital for the regular injections. So after 3, 4 injections, that child was completely freaking out. But they insisted, they restrained the child and so at a certain point, the child took a medical device and hit the general practitioner. That was the moment that she was referred to us. So a moment of wisdom in the girl. So you see, no one had seen the trauma in the child unless the trauma became a problem for the providers. That girl was so traumatized that we tried every sedation. She just was so programmed, her whole stress response was so active that no sedation worked. So that girl for the first 2 years went for general anesthesia for an intramuscular injection. You see the mismatch here? Because we caused a trauma. In between, in those 2 years, she came before anesthesia, always to our unit, to get adapted to our unit, to meet the people, to practice, and then she was prepared, child-friendly, to the operation room. We started exercising, learning, becoming competent. And so once she reached the age of 6 months, we moved on to sedation. And when she was 9, she was able to inject herself. So you see, that's the learning part. If we hadn't used anesthesia at that point, we would never been able to do anything with her. So you see, anesthesia might be needed for a very simple procedure. Is there a child needing help? Should we go in there and do something?
Yeah, I wanted to comment.
Yeah.
I want to say something about your point. I think it's very important to be able to make an accurate assessment. So in other words, to identify these kind of children early. Because often what happens is that we identify them at the time that we're doing the procedure and then it's a very difficult situation to deal with.
Yeah.
Identifying and then applying different strategies, whether it's home preparation strategies or other preparatory strategies or trauma desensitization, is very useful. So what I would say is that that the emphasis should really be on identifying these children.
Yeah.
Identifying children who you know are going to have this kind of response, and then being able to develop certain strategies. And the more proactively, more ahead of time one can do that, more useful it is. Yeah. Obviously, the parents can give you some insight there. Past medical experiences can give you some insight. Whenever I see a child whose anxiety is out of proportion to the current situation, I'm already thinking, this child had a negative experience. I need to delve into that, see what would be the most appropriate way to manage them. So I'm just advocating for, in this sense, an assessment and hopefully proactively being able to identify these kind of children. And then there's things we can work with.
Yeah. And now we've changed our whole management. When a child is now diagnosed with this disease, the endocrinologist prescribes the medication, but then the child is referred to our PROSA team. We have a dedicated team for these complex challenges, where nurses, doctors, child life specialists, psychologists work together. And then we define what does this child need right now, but always with the learning goal in mind. So then we avoid the thing, and when the child learns to trust us from the very beginning, everything goes much easier and becomes cheaper and much easier in time as well. So you see, you see how we changed over time. Okay, so let's dive a little bit in this, for example, in that girl with the procedural distress. What are we speaking about? Procedural distress, so the negative energy, the negative stress during a procedure, a simple way of looking at it is considering it as a combination of three things. It might be the pain of a procedure. If there's a needle, it might hurt, it causes stress. It might be the fear of the procedure or the expected pain or the environment, fear. Or it might be the focus, just the attention, the emotional status, the attention. And of course, you can imagine if I would take a big knife and I would start cutting in your leg now, you all agree that this would cause distress. You agree? And I don't know how it is in Iceland, but I think it would be the similar response. That's what's happening here.
That comes by every 15 minutes.
Yeah. Is that, or are they preparing a dinner for us or something like that? I have huge expectations now. It's wow. So pain, you can imagine a lot of pain. Fear. If you're fearful for needles, the pain might be minimal, but then the fear will dominate your emotion. You agree? Fear. When you're fearful for certain animals, fearful for certain spaces or whatever, your stress might be huge even if the pain is low. And then focus, that's the attention. And I always used to give the example of the typical syndrome called the male flu. When men have a flu, they don't have pain, maybe a little bit. There's no fear, but they are suffering, you see. So that's focus. And now we know that on the Y chromosome that our inflammatory system is a little bit different than yours. That's why we suffer. Sorry, there's scientific proof now for why we behave that way. But you see, this is like what we are facing when it comes to a procedure. And the advantage is, if you look at this model, you can consider it as three wheels where you can turn around. If you have a child and you want to minimize procedural stress, consider those three domains. And of course, for pain, we can give pain-killing strategies. I'm not going to explain you about EMLA. You all know EMLA, I believe. I saw in your email that increasingly EMLA is considered like the standard of care. There are alternatives, but there are BUSY, there's shot blockers, there are other things. There are buffered lidocaine. There's so much where we can speak about, but that's maybe for another time. But take pain away is crucial. It's not fair to distract the child for something painfully where you can take the pain away. Distraction is never the alternative for pain strategies. That's very, very important. And we've seen that so many times that people buy, for example, virtual reality goggles as distraction, but then they don't use EMLA because that takes 60 minutes. That's a great tune. What kind of music? Do you recognize the music? Was a famous movie, I think. We should ask her. Okay, now I'm refocusing you. So pain, we should treat pain always. When it comes to fear, it might be interesting to analyze what actually reduces fear. And it's not that simple. It starts with basic comfort conditions and relaxation. When your parents are around, or certain rituals, or your cuddle beer or whatever, that's what makes a setting child-friendly. Skin to skin. Also, try to avoid that the child is hungry. You know hangry? You know that? Hangry? Yeah? My wife is a typical case of yes, she is. And I am allowed to say that, but I'm now fully trained in managing her hangriness after 28 years of marriage. I'm successfully in diagnosing in time and treating in time, especially the last is crucial. But you see, if a child comes in the afternoon for a medical procedure and they skipped lunch, for example, by travel, and they come in hungry, these children are fearful by nature. They are in stress. So don't try to connect. First, give them a bottle of milk. So you see, or they are in pain. They come with pain in the abdomen because they have an abdominal problem. You see them in the emergency room. You can try to reduce their fear, but if you're painful, so first give them paracetamol or pain-killing things so that actually that goes away. That's basic comfort conditions, so crucial. The second thing is communication. That's, oh yes, please, a question.
I'm just wondering about parents maintaining bad behaviors or like pushing under more fear or
Yeah.
what do you do?
The parent. Do you have... Who is a parent here? Who is a parent? Oh God, she's blaming all of you. I'm a parent as well. You're a parent as well. So we are all parents. Most of us are parents. Can you explain again, please?
And we do reinforce bad behavior.
We do reinforce bad behavior, you say. So can you maybe a bit more explicit? Where is the parent a pain in the ass for procedural comfort care?
Playing a role in maintaining their children's behavior,
Yeah.
bad behavior,
Yeah.
or
Yeah.
they are showing their fears through the
Yeah.
children.
Yeah.
Something like
Yeah.
that.
Yeah. Yeah.
Because I feel like parents are often the reason why the kids are
Yeah.
really
Yeah.
fearing the situation.
Yeah. Let's take a picture of a parent. This is a father. You see? I took a father, not a mother. Sorry. I fully agree. Parents are a real challenge. And there's not so much literature about it also. But we start to understand the position of the parent. And actually, this picture is maybe a nice example of it. First of all, when a parent comes in the room for a medical procedure with a child, they might be in a huge state of confusion. And let me give you one example. Do you have a child? How old? 3 years old. Imagine you come in September to Maastricht to the PROSA conference and you bring your 3-year-old with you. We have in Maastricht this beautiful square. It's under the trees. You can drink a lemonade or a beer. We have great beers, but not for your 3-year-old. And you're sitting there. Okay, imagine. And I come along. I say hello. I take a needle out of my pocket and I start puncturing your little girl. What's your response as a mother? Mm-hmm. Just try to think about it. Okay. And then we'll check whether that's a natural response or not. What kind of response do you think you have? Confused?
Yeah,
Will you say, yes, please, Piet, welcome, go on puncturing? Oh, is this a tradition in Maastricht that they puncture all the time? I don't know how aggressive people in Iceland can be, but I think at least there will be some aggression in your behavior. You will defend your child, you agree?
Protective.
We all agree that is that proper behavior? Yes. Okay. Let's change the scenario a little bit. While you're in Maastricht, it's just a simulated case. So imagine that while you're in Maastricht with your girl, that she started on a morning having these blue spots on her skin, hematoma, and that you go to a doctor, and that they found some enlarged lymph nodes, and they say, oh, this could be leukemia. And you are referred with your daughter to the emergency room in my hospital, and I come again in the room with my needle to puncture your child and to do a blood sample. What's your response now? You will be grateful for my behavior. So the same needle, the same procedure, the same diet, but a different context. And I would be very happy that you would be a good mother if you would help me. If you start defending your child, then we say, wow, that's not a good mother. So you see, that's already showing a little bit with this simple anecdote. It's showing already the state of confusion that many parents have. They are in an impossible position, defending their child, maintaining normality, managing their family at home, going on with their job and their work, helping you, feeling the frustration of not being able to comfort the child while they are experiencing fear and pain. And I'm just mentioning a few layers now of the complex emotions that parents might face. All of this is what parents bring in the room when you expect them to behave in a way that they could help you. And I'm not trying to formulate an excuse for parents.
But what do you think? Do you think it's necessary for the parents to always be a part of the procedure? What
Yeah.
you do?
Yeah,
I'd
that's
say-
it.
Yeah.
Yeah, that's a great question. What do you think? What do you think?
No, I don't think they're all always necessary to have them because sometimes they are just, I don't know, not helpful to the situation.
Okay.
Maybe their fear is coming through the kids.
Whatever?
Yeah.
Yeah.
They
Yeah.
know that you're helping, but
Yeah.
they fear the situation themselves.
Sure.
So,
Yeah.
So-
And any
So the
yeah.
child,
Yeah. Yeah. Yes. Please comment, Baruch.
so I want we talk about, we have a unique term in pediatrics that we use called the dyad, which in Latin duo for two, it represents the parent and the child, the dyad. And as we know, they are really functionally one unit. They're constantly reading and regulating each other's emotional state. So one of the things that we spend a lot of time focusing and assessing the child's emotional state. I do the same thing with the parents. I want to know how effective the parents are, given what Piet has talked about, the context, and all the things they're feeling, how effective they are in their own emotion regulation, right? And I basically divide parents into three categories. One, where they just don't have any emotion regulation skills. They just can't regulate their emotional state. And we've all seen these parents. They're just spilling their emotional state onto the child, onto you. They can't really regulate that. There's another category of parents where they have emotion regulation skills, but they're overwhelmed by the current situation, right? There, you can really work with the parents, give them a task, help them really help them in managing their emotional state and being focused on the child's experience. So they really understand how what they're transmitting to the child can affect the child's own experience. And then there's the category of the parents is you walk in the room, the parent is already, taking care of the child, position the child. They're really not only fully emotionally regulated, but they are also helping you in facilitating that. That helps me determine which parents I think shouldn't be in the room and would be helpful, those who really can. Yeah. So that's one way I'm always really assessing the dyad's emotional state because they're so, as you say, they're so interconnected.
Yeah. But it's highly delicate. And what we have learned over time is that, and this father is actually an example of this, that many parents who are actually not behaving the way we would like, that actually it's a sign of severe distress, usually based on negative experiences they have had as a child. So they just don't know what to expect. So if I go back to my slide here, on fear reduction, basic comfort conditions is also applicable for parents. If a mother or father comes in and has to assist, but they are hungry, or they have a full bladder, or they are whatever, they're not able to support you. So the same what I mentioned here for the child also is relevant for the parent. If it comes to communication, and I come back on the parent in a minute, the way we communicate, what we encode, the words we use, make a huge difference. And one of the things there is respecting interpersonal distance. That's the distance between people. We all have a certain area where we actually feel safe and where we don't like someone to jump in immediately. I could test this. See how close I could come. And there might be a moment that it becomes embarrassing for you. She's an adult. She's a woman. But a child is the same. So imagine the diet. Imagine she's having a baby on her lap. And I'm approaching. These are two interpersonal distances that might be completely different. The child might be welcoming, but for the mother or the father, it might be, don't approach me too quickly. for any reason, have we taken that into consideration, the way you approach? Especially if we immediately dive into the physical symptoms or examination or whatever, then we come very close, could trigger immediately a stress response. So the way we come in might shape different expectations in the mother and the father as well. And then the third point is predictability. Imagine that we would have started our lecture here, that we lecture together, but we always have a surprise after like about 30 to 60 minutes. We do something very odd, and usually it has the effect that some people will start crying and have very negative emotional responses to that. But we will not announce the moment. Can you imagine that in that way, if you would listen to our story with that expectation that at any time there could happen something negatively, your stress response is on all the time. Now turn it back to the clinical situation. Father and daughter are waiting in a room for a needle puncture. They're waiting in the room, the door is closed, and the only information they get is someone will come for the blood sampling. Every time the door opens, the blood sampling might start. Unpredictability. If a parent doesn't know what has to happen in the procedure, they don't know what's expected from them. So they will start improvising, using words that are not appropriate for that moment, but are based on their whatever they might expect. Some parents have never heard about amla cream. They think that the needle hurts. So apparently you have not informed them well that their child will not suffer pain. So most of the stress responses in parents are the consequence of a lack of predictability and a lack of good information or practicing. For example, this boy here. This little girl has a disease that she inherited from this man, her father. So this man, as a boy, was tortured in the old way. When his daughter was diagnosed with the diagnosis, he freaked out completely. He didn't know how to behave. But she needs IV medication every 4 to 6 weeks. So we practice, without puncturing, we practice. And now they prepare each other at home. They regulate together. Look, she's sitting on his lap. He's close to the procedure that he is even not yet able to do without sedation. So close he is with his daughter now.
So close. Look how the posture, the facial expressions are completely matched.
Daughter and father. See? So that was the typical abnormal father who would say the wrong things. And look to the predictability. How they practice at home. And they use the same materials. So for the girl and the father, they knew exactly what was going to happen. And of course, the team needs to know that. That's a different way of facing this challenge. Do you get me? And still you asked us, do they always have to be present? No. In this domain, there's not an always or a never. Some parents have to be given the opportunity not to be there because it's better for them, better for the child, better for whatever. But don't forget one thing. It's like Baruch said, it's a diet. So if you separate them, they will come together again, you know, after your procedure. If you have separated them, you don't know what they are going to teach each other afterwards. That could be very negative information about the whole encounter. You don't have any control over it. So keeping them together, now applauding them for how they behaved and what they did, and explaining how well they did it and why, shapes the next encounter. Do you see the learning process here? And if you divide them, you don't know. You're out of control. So that's why we actually, as a principal perspective, we keep them together. But there might be exceptions. And some parents might be so stressful that they're actually happy that you let them go out. Sure, but then restore the relationship afterwards. Is that an answer to your question? So it's a great question, so relevant, but it's the same challenge as the child, actually. Any question on this or comment? I can't hardly see you with this spotlight on it, so that's why I forgot my sunglasses. No one told me to bring sunglasses to Iceland. You even forgot an umbrella to bring. Okay, you get this? Is this? I love this picture. There's so much in this picture. So then the other part is the navigating the emotions. That's a whole other skill set. That's actually where Baruch talked about last time we were here with the great videos of your publication. And that's a matter of carefully observing emotion of a child, to watch a face, to analyze what kind of emotion would be there, to give it meaning, not to just say it's fearful. No, there might be other emotions around. And then the whole engaging. How do you connect with a child in the playful way like you have seen the bubble blowing? That's the challenge. It's about playing, actually. It's about purposefully playing. Your kids in Iceland, they play? Okay, that's good news. Anyone who has played over the last week? No one plays? Who is treating children? You should play. You should play. Pediatrics is about serious play, actually. So we forgot, maybe as professionals, to play, to read emotions, to connect. I see you, you see me, and then start something that connects us together. And in children, it's play. It's about play. Are you going to explain this, Baruch?
I think you just did.
Yeah?
Yeah.
Yeah?
Yeah.
So this is the cycle we just mentioned. And you can compare it with how we used to work in other clinical conditions. When you see a patient with dehydration, ever seen a child with dehydration? Mm-hmm. You know that, dehydration? Yes, you know that. And you know, you have these children who are a little bit dehydrated, and then you have those who are in a deep shock. Do you see that? You see it's a spectrum. It's not about normal hydration and dehydration. There is steps in between. You agree? That's how we typically look. And how do we do that? I see you nodding. We follow the same school. So we are trained in the same way. When we see a clinical condition of a patient, we observe. You agree? The child comes in. We see signs. We see some eyes, the saliva, the skin, whatever. And then we assess the hydration status. Okay? And once we've done that, we say this child is mildly dehydrated or moderately dehydrated or severely dehydrated, or this child is in shock. We give it meaning. You agree? And depending on the meaning we give it, we engage with the child physiologically. So we treat it. We rehydrate it. But then we're not done. We measure our effect by observing the effect. You agree? So this circle is actually what we do every day again. You agree? You see the circle? So it's in our training to have this kind of systematic approach. Now we challenge you to do the same for the emotional status of a patient. Also to try to, not to say, this is not a good parent. No, try to be precise. For dehydration, we don't say, he lacks fluid. Okay, that's it, that's a diagnosis, lacking fluid. No, we are precise, you see what I mean? And the same for a child coming in with asthma. We are quite precise in the respiratory distress so that we can communicate with each other. If you call a doctor, you can say this is serious or not. Let's try to do the same for emotions. So we observe. And it would be great to organize a practical exercise here. But the day is already, it's like already 5 o'clock, but it would be great to ask everyone to watch her. And then collectively assess her emotional status by reading her face, her position, whether she's calm or moving or stressful, and then also read the context. Is she hiding her face, or is she showing her face to me? Is she close to her mother or father, whatever? So reading the situation. Just take 1 or 2 minutes to do that purposefully. Like we do in the child with dehydration. We just, in a dehydration case, we just don't walk in and say, lack of fluid, get out. No, we check carefully. Just take 1 or 2 minutes. So then we give meaning to the cues by assessing the emotional status. And what we've published, and actually comes from the work by Baruch, is a kind of just like in dehydration rehydration axis, there is this axis between fear and trust. And here's the trust axis, the fear to trust axis. Fear at the left, trust at the right. If we go to Arabic countries, we turn it around. So, because people then read from right to left. That's, no, we haven't been lecturing in Arabic countries so far. So, whoever comes from Syria here, please invite us, we're happy to come. So the fear to trust axis, there are some steps in between. Let's start with fear. Close to fear is uncertainty. Try to figure out for yourself, how would a child that looks uncertain, how would that look like? Maybe watching you when you come in, not knowing whether to respond or not, hiding between its mother. It's uncertain about what's going to happen. You could have been here in the beginning of our meeting here, very uncertain what's going to happen. There's a guy from the Netherlands, there's another one from the United States. What's going to happen? Uncertainty. You're very close to fear. You get it? Uncertainty. If you walk home in the darkness alone, you're close to fear because all the uncertainty that might happen. You get it? Uncertainty. If I want to get you away from your uncertainty, I need to catch your attention. The best way to do that is arousing your curiosity. We are curious species, especially children are curious. So we can use their curiosity. You do something unexpectedly, you introduce something, you get their attention by activating their curiosity. Once you have their attention, you want to have their attention.
So I should say one thing before
Yeah.
that. Along with uncertainty, apprehension.
Yeah.
And remember, these are just,
Come to the microphone, Baruch.
these are just points along. What you want to do is when you assess the emotional state of the child, you want to plot them on this axis. Where are they? So you can individualize how you're going to respond to them, right? And the closer you are to accurately assessing where they are on here, the more effectively you can engage them. Now, Pete's going to lay out the whole thing, and I think you should just lay out the rest of it. Okay, so here, what's important? Yeah, what's important? Can you hear?
Yeah.
What's important to say here? This is not working. Is this?
No, it's not working. It's just for the streaming.
Oh, it's just for the streaming. I got it. So here, let's say you have a child, and you plot them here. Actually, if you plot them all the way here, there's always this child here in this situation. You always start with desensitization. That's one of the engagement methods. You have to desensitize the child to your presence so they're not reacting so forcefully. Here what happens is you're doing cognitive reappraisal. That's part of the engagement. This child sees you, their appraisal of you is you're threatening. They have a resultant emotion. They're afraid. Yes? What you want to do is be able to shift them from seeing you as threatening to seeing you as non-threatening, because that will generate a different emotion in them. And that's exactly where this happens. If one is effective in cognitively reappraising the patient, we'll talk about that in the engagement methods, then all of a sudden you're no longer threatening, so they're wondering, what's going on here? But not in a negative way. What's going on here? Who is this person? What's happening here? And you can see a change in facial expression. Facial expression softens. Posture opens. This is part of the behavioral response that you begin to see with this. So I just wanted to point out that piece of it. And then the rest is attentional control. Can't do anything with children unless you are able to capture their attention and then direct their attention, guide their attention to where you want it to be, which is away from what you're doing. Yeah? And then the rest is just points where you begin to see, okay, now we're really connected, and now we're... and this becomes very important because seeing... Pete was talking about before about parents dealing with parents. One of the ways I deal with a parent who I assess is very anxious is I start engaging the child. And as soon as the parents begin to see any motion in the child along this fear to trust axis, and they will sense that immediately, then they begin to relax. Because their only concern really is, am I going to take care of their child well? Am I going to emotionally contain and hold that child through what needs to be done? And as soon as they experience any motion in this direction, not only does their anxiety go down, but a very funny thing happens. They give me confidence. Yes? Because they're seeing this. They're feeling this change, this experience. I teach the medical students, I teach this course with medical students and residents, and I tell them again and again that don't focus on, I'm not yet a doctor, I don't really, I'm not really that good. Focus on the child, and if you're able to begin to affect the emotional state of the child, then the parents will see you as competent. They won't say, could you please get your supervisor in here to take care of it? Anyway, so
Yeah.
I just wanted to say about this piece of it. And it's very helpful to be able to see the motion moving along. Because as Pete was talking about, this is a very iterative process, right? It's not formulaic. Oh, he's a 2-year-old, she's a 2-year-old. Oh, every 2-year-old will respond when I blow bubbles, right? It's an iterative process. You have a hypothesis about what the child's emotional state is, and then you're testing it. And if your intervention is appropriate and is directed towards that, where that child is, and you see them respond, then you're on your way. If not, then you step back, you readjust. So you have to be very iterative about this kind of process.
Do you get this? And that's interesting, because once you meet the child and you start engaging with the child, but you're only like at the field of attention, but they're not yet engaged and working with you, then it's too early to start a procedure. See? So this is also a very important step. That very close to trust is working together, being engaged and actively engaged in any conversation you have with the child. And maybe those who work with iPads, maybe people use iPads as a distraction. So the distraction is not in the iPad. The distraction is in the interactivity between the child, the iPad, and the people around. So that interaction is important. And we also know that, for example, just observing things that happen on the ceiling or on a TV screen, if the child is not in that play, and you as professionals are not in a certain way also engaged in that play, then it's not going to work, because you need engagement for trust. And once that's working, it might go on. If you just use distraction, distraction, you're distract for a moment, that works 5 seconds. And then I need to distract you again. And then I have to take a clown out of my pocket. And then I take a bubble blow. And so that's impossible. Once you're engaged in the same dialogue, it goes automatically. Like the girl you saw on that picture. She was here on that picture. Look, the 3 of them, by the book, they are in one engagement. That's why it's so successful. Not because of the book on its own, not because of the position of the child on her father's lap, but they are in the same dialogue with the same challenges. This girl is challenged to look for figures in that book, and she's solving problems. She's challenged to move further, and she's engaged in the same challenge. That's close to trust.
Yeah.
You agree?
I wanted to say one other thing. I know you had wanted to say something. I wanted to say one other thing. This thing that I was talking about cognitive reappraisal, and how does it move a child, it is not time-bound. This isn't something that takes a long time. Okay? I want to give you an example. I went in to see, a couple weeks ago, I went in to see a 9-month-old, was really 8 or 9 months, sitting on the parent's lap, really apprehensive, way on this, right? So here I am, I walk in the room, and this is how I gauge the situation, read the room. This is how I introduce myself to the child. First I said, hi, I'm Dr. Krauss, to the parent, you know, and I went close to the child, but with some distance. And I took my fingers, and I looked at my fingers. And then I went like this. I looked at the child. Child looks up at me. Smiles, touches my finger. That was it. Right. So,
curiosity, again, and moving to engagement. So this is like, there's a goal in his mind.
but it's more than that. It's knowing where that child was developmentally.
Yeah.
They are very interested in eye-hand coordination and fine motor activity. They're working on that. He said, well, oh, God, I'm working on that all the time. Here, let me just do it.
Yeah.
You got it just right, you know? And then there was play. And now, all of a sudden, there's agency. He's got a little control. And predictability. He knows what's going to happen. And familiarity, yeah? All of a sudden, something's familiar to him. So, and my job was to move into that room, to begin a relationship, move from unfamiliar to familiar, from unpredictable to predictable. Now I've got him, we're on our way, and we can do what we need to do.
Yeah, you get it? Have you noticed how slow he was doing this? Can you tell something about this, the pace of what you're doing? You slowed down.
Right, well this is for him, was a complex motor task. So not only complex motor task, but he's reading me, right? So he's taking in my face, they're, as all of you know as parents, very early on, they're watching you very carefully, yeah? So he's reading me, and at the same time he's watching the task and thinking about how he's going to do that, you know, the motor piece involved. So his cognitive processing, I got to go slower. And notice I repeated it a couple times. Yeah, got to give him. A lot of times we find that, I find that I have to tell the medical students, residents to slow down as you're interacting with the child. And part of that is also, one has to be authentic and transparent. And part of that, being able to slow down, is just that. It's communicating that. I'm here. I'm right here with you, focusing just on you. You know, and again, it's not time, it's skill. It's a skill.
Yeah.
So it's not.
And adjusted to the developmental age of that child. And I think that's one of the biggest challenges for all of us. Purposefully playing, interacting with this in mind, adapted to that specific child, is something none of us have ever learned. We know everything about abnormal development, but connecting with normal development is something, it's not in our communication trainings. So here is if there is a next step in your process here, it would be great to start training amongst each other for, let's look to a child of 2. Let's look for this child of 4 years old. What kind of playfulness could we deploy in this child? What could we try? And what Baruch always says, it's not about a protocol. 3 years old, let's take the bubble blow. 4 years old, let's call the clinic clown. 5 years old, let's put the iPad on the face. That's not the way it works. These are the tools that are in your box and that you take out once they can help you. But it's about this individually adapted approach, which is so crucial. And I think we can all still learn a lot about this, especially practical tools, how to deal with this in daily life. But so you get the access now? So the next, when you come home this evening, you meet your partner, wait a moment, observe. Put him or her on the fear to trust axis. I could figure out other axes as well, but that's up to you and to your creativity. And try to engage. And you never know what the night will bring you. It's, yes.
My question is about the direct interaction with the parent during this process. I mean, are you involving, like, you're getting the child's attention and evoking their curiosity and all of that, but the parent is there on the side. Are you involving them as well?
Could you repeat that? And go
Yeah, the question is here, if you if you start interacting with the child and the parents are around, do you involve them in that process, or do you first focus on the child and then you see how parents follow? Or so try to put it in the whole complex context of parent-child around.
Yeah. I think that's a style point. We all have our different style and our approach. Mine is I typically this, and again, this is my style. I typically say hello to the parents, like, "Hi, I'm Dr. Krauss," and I immediately turn to the child, because I find, and this is just for myself, I'm saying, I find that if I go into a room with a child who's over here to start with, it doesn't matter whether I start with the parents. I could have a long conversation with the parents and then turn to the child. Everything would be fine. But I find that the children more skewed to the fear side, they're watching me. I'm a stranger, and I'm not addressing them at all. I'm starting to have a conversation with the parents, and if a child is injured or they're ill, most of what I say is usually not comforting to the parents, because they know things are going to happen. And so the parents, I'm not modulating the parents' anxiety state. They're still communicating that to the child, and then I have more to overcome in terms of getting the child. Again, that's just my style. I'm more comfortable working that way. Well, how?
It's contextual, it's situational, but can you imagine a child of 3 who in this stage, and you come in and you start talking to a mother who has a lot of questions about her child, mentions a lot of words. Oh, he needs a blood sample. Oh, the last time this was a disaster, the blood sample. All kinds of words that fill in the space that will also have an emotional impact on yourself as a professional. So can you imagine what happens in the child? So then we don't have an axis here, but then probably the child moves to this part. You see? So that's the whole, and there's not one sacred approach here. I'm an intensive care specialist. So now and then I go with an ambulance to another hospital to retrieve a critically sick child. For example, a child with severe asthma who is continuously on the nebulization, who has IV medication, who's breathing like this. And still when I come in, I present myself to the parents. I'm doctor from this department, but I first want to meet your child. I'll come back to you in a minute. So I just make it predictable. You see, if you don't say anything, oh, there's a stranger coming in and he has this kind of green, we are like dressed like these ambulance nurses, so in full color. So we are very impressive, full of testosterone. No, it's not the case. But that's how we come in. That's how we come in. So imagine that's a quite aggressive intro. So I first want to make me small and meet that child. Not only to connect with the child, but also because I want to see the child. And very often there's so much stress in the room that a part of the respiratory problem is the stress in the room. So that's a choice you can make, but always think of all parties around there. First want to meet the child. Yes?
I was thinking about the removal of some, like the child or the parents, because like when you are introducing some procedure you're going through or something like that, and you're explaining how it works.
Yeah.
Something you don't want the children to hear.
Yeah. Yeah.
Like when is
Yeah.
on and off for
Oh yes, that's a great.
supposed to hear and whatnot.
That's a great question. Here, then I go back to this one here. The communication. How to be honest and fair in your information, but not use the wrong words. And that's the whole field of therapeutic communication. That's a whole research field nowadays. And I don't know a version in your language, but it must be a great adventure to design, to translate Comfort Talk, which has been published as a language model. How do you explain to a child that you want to puncture the child without using words that will frighten the child? So how to be honest. You can't cheat the child because that's something you do only once. You want to be honest. And we even are forced to do informed consent. But just simulate this situation. If this little girl is fearful for vaccination and I tell her, okay, I count to 3, 1, 2, 3, here comes the needle. That's full of negative expectations. And I can have even promised that this will hurt because what's going to happen, more and more tension in the muscle, and at 3, the muscle is like this, and then it will hurt. You see? So how to be honest and correct, but don't use the wrong words. By the way, this therapeutic communication is much more than only using the right words. It's also to make your own life more easy. If this little girl from 5 years old, you ask her, shall we do the blood sampling now or later? What do you think her choice will be?
Later.
Later, and probably never. But if you make her a choice, shall we do the blood sampling your left arm or right arm? You give her a choice, she's in control, but you have thought about the choice. Shall we do the examination while you're sitting on the bed or on the lap of your mother? And then start practicing these sentences like, if you hold your arm like you do right now, you'll see it's over in a minute. And when you're done with the procedure, you did such a great job, and I'll tell you why. Not just saying you did a great job. If we thank you as an audience later on, thank you, you did a great job, what have you learned? Nothing. Even if I take out of my pocket a present for you to thank you for your presence, what have you learned? That you got a present. But if she held her arm still in a great way and was sitting close to her mother, okay, we did a great job, and I'll tell you why. You were holding your arm in the perfect way, and your mother, she was doing such a great job while she was singing that song for you. That shapes their memory for the next time. That is the story they will share with each other in the car home. When they come home and there is a father or another mother or whatever, or grandmother, that's the story they will tell. That's the story they will come back with to you the next time. Do you see the meaning of communication, how crucial it is? And indeed make choices. You can't start explaining a procedure, a needle here, a needle there. By the way, if we use EMLA correctly, it's not going to hurt. So why should we warn for pain? You see the 3 circles? Mm-hmm. You get it a little bit? And I would love, this would be a great next project. Translate Comfort Talk in your own language. I don't speak, do you speak Icelandic language? How well is your Icelandic language? It's below 0. We can't even read the words. I will never be able to pronounce your name probably. Like you were quite okay with my name. So that would be a great project to work on. What words could you use and practice, and what kind of common language could you develop to explain things to children?
Yeah, and I think in terms of this honesty and informed consent and communicating like this, I think it's very important to appreciate that you are an authority figure, at least from the way the child is seeing you. And so your words carry great meaning to them and can affect their state. So as Pete was talking about, one always wants to speak in a way that doesn't create negative expectations, but could create positive expectations. And part of that is, and there's another piece that I want to put in there. All of us know and have seen that children have many different responses, yes, to the same stimulus. For example, we've all seen children who get IVs, they put the IV and they're just looking. They're just looking. We've all seen those children. Very surprising when we see that. And we've seen children in all different, yeah? So I'm very careful as an authority figure not to suggest to the child what they would feel, particularly if I'm uncertain about what they actually might feel, because that is already, from my perspective, stacking the deck. And I'll give you an example. This is a simple example. Oftentimes, say a child's having an allergic reaction, and we're giving them some intravenous diphenhydramine, Benadryl. You're familiar with that medication. That can cause a little bit, as it's taking effect, as the central nervous system levels are going up, they can feel a little dizzy. Yeah? So I never say that to them. Often I've seen people say, they're saying, well, you may be feeling a little bit dizzy when you get this medication. I don't want to suggest that. So when the child gets the medication, I say to the child, maybe after 60 seconds, 2 minutes, I say, you may be feeling some of the changes from this medicine. Okay? Now it's completely open for what their experience is, and I'm not creating a negative, you follow what I'm saying? So there's really a real discipline in learning how to speak in such a way where you are honest, but you're also in such a way creating a positive expectation and avoiding negative expectations with the child, or suggesting in a powerful way as an authority figure what they will feel, kind of shaping their, you with me? And all of us have been in a situation where, you know, we're very vulnerable, we're feeling sick or something, and there's a suggestion about what we may be feeling, and that kind of shapes.
In our courses, we actually do practical exercises where we look together for new sentences. For example, if you want to give a medication against nausea, how could you say that in a way without giving the suggestion that could cause nausea? After a surgery, child is waking up from anesthesia. What do we typically do in the recovery department? We put one of these kidney-shaped things next to the body for the case you might vomit. So here's a suggestion already. And you know, we know now from neurobiological research that this is extremely strong. When you expect nausea, you will develop nausea. And vice versa. So these, we call them nocebos. That's the opposite of placebos. Nocebos are words that create negative expectations. And these negative expectations, when you create them, they're in the mind and they become true. But we are very fortunate. We also have the whole science of placebos. And that's actually adding positive expectations to it. And we now have research where we give patients pain-killing medication. And they were divided in 2 groups. One group there were post-surgical real patients, adult patients. One group got the medication, the pain-killing medication 4 times a day, but the dosing was hidden. So you didn't see the medication, but it was given to you. So for example, 1 gram of paracetamol every 6 hours. Correct dose, it was given to you, but it was given in a hidden way. It was by the perfusion, but you didn't know that your painkilling was given. And in a second group, same dose, same regimen, but then a human being came in. I'm a human being now. And I touched you in a certain way. I said, I'm here for you. I'm back here for your medication that will help you to feel better. It will start in a minute. Okay? And then they compared the pain scores between those 2 groups. And you think what's the surprise is? the pain scores in this group, pain medication together with humanity has double force in pain reduction than the medication on its own. And the nice thing is that in the group with no personal attention, of course, the pain scores went down after the medication, but in the placebo group, the pain scores went down already before it could be due to the medication effect, just because of the humanity. That's the strength of positive expectations. And of course, don't use that when you're going to do an amputation in a patient and say, we don't do it with anesthesia because it's positive expectations. Oh, you have another very good leg. Let's focus on the left leg while we take... No, it's all in balance. But just walk around tomorrow in your own department and just scan for negative expectations, negative information. You might feel pain. It might be this might be the complication, etc. And try to rephrase that in positive sentences. You puncture a child and the child asks, is going to hurt? Might be, but some children, I'll tell you what, some children don't feel anything. Some feel that you touch it a bit. Some feel this. I'm very curious what you will feel. Whoop, you turn it around. And your suggestion is open. And you're still completely honest. And if you've used AMLA correctly, you're quite sure that they might feel something. They will feel the touch. They might even feel a beginning of pain, but then they're not warned for something. You see the difference? So please design Icelandic versions of comfort language. That would be a great initiative. Yes?
So you don't believe in suggestion of what they will feel. What I usually do when I use nitrous oxide is I tell them the effects that is affected, and I tell them at one moment you might feel dizzy, and that's good because that means it will work. Because I've seen it many times that when they start feeling the dizziness, they just say, oh, I'm losing control, I don't want this. So I actually suggest to them that this dizziness will be
I think, any strategy is a good one.
Well, first of all, I should say that you started up by saying, making a statement like, I don't think that that's not correct. Okay. Not at all. I use exactly the technique that you articulated all the time. Yeah. They're in a suggestible state. Yeah. I want to,
But I might use different words. Some children, when they start inhaling, they get a little bit the feeling as if they're like flying or become light. And you know what? You felt that feeling, just look into my eyes, I'll guide you through, whatever. So you see the difference in wording? It's not warning for something, because it could be that they start checking for the dizziness, and that when it's not coming, that they might be even confused. So suggestion is a delicate thing. But some children are happy with the warning, so it's personal. It's a personal thing. Okay, we are... Are you still with us? I think you are. Final slides.
That was all.
Can I ask one?
Oh, sure, you can ask any question.
So,
Wait, I'll do this first.
a child has to come in every week, and you have worked the steps all to the final day. You have a happy child coming in, consensual, you have a really supportive parent, and the child is really ready and really wants to do the procedure to get the needle stuck here. At the final, every time, in the final moments, it's prepared, you can clean it, but then the panic sets in. And you try, breathing exercises, iPads, everything like that. Every situation is, but the final 30 seconds is always the most difficult. How do you test do that?
That's a very good question. Usually, you can even see that while children have nitrous oxide, for example, or light sedation, that they go with you, they are brave, they want it, they understand it, they are there to prove, and then when the real moment comes and some signs get in their mind that it will start, they freak out. And first of all, it took me a while to understand that process, but thanks to what we know from neurobiology, we now understand what's happening. What you see there is a highly programmed stress response in the amygdala and the hippocampus. So the amygdala is that's a difficult word, but it's the center of our stress response. Any sign that any second, millions of signals are entering our nervous system. And they are all scanned immediately at that side of our brain. Is there danger or not? That's how we work. Once you have had a traumatic experience, there might be like an automatic cycle between your hippocampus, which is a part of the memory, and your amygdala, which is a stress response. If you go to the brain and the anatomy, you'll see that they are like immediately corrected with each other. It's a very fundamental, basic system that, imagine that you're living in the rainforest, and one day you stepped on a snake and you were hit on your right foot. Then it's good to have this automatic warning for the next time, that at least any suggestion of a snake, that you run away. So it's a very old system of our survival. Once you're traumatized, and I'm sure this kid must have had very traumatic experiences, this cycle is an automatic cycle. It cannot be controlled cognitively at that moment. So anything you do will end up in the same moment. And it's very often for those kids a real source of feeling ashamed, embarrassed, because they really want. Here's a difference between reasoning when you're quiet and then ending up in the situation that just your brain is automatically recognizing a dangerous situation and switch on the button. That's the situation. Now, fortunately, yes, please.
Yeah, and so the conditions there do not exist for an intervention like distraction or this. They're not taking any of that in. So, nor is it useful in that situation. I know in certain situations it's, let's call the clowns in now. Let's bring.
No.
That's
they freak out.
That's not going to. Yeah.
And they can't control it. It's out of control.
Yeah. And so.
So here are some strategies. First of all, now we know that these children, you can treat this severe trauma. It's actually imprinted trauma. You can treat it with good psychological treatment. We have now this EMDR, for example, or cognitive behavioral therapy. There's a whole field there where these children need treatment. Because that little girl, one day, she might be pregnant, for example, and needing an IV access for something. So it's important to treat that. So you should consult a child psychologist, and there are strategies where actually that can be taken completely away. So that's the good news, but it might take months. And it's a challenging endeavor for the child. My own daughter was highly traumatized during a vaccination. She had the same cycle. When she was 14 years old, she wanted herself to come over this. And it took her a year, and now she can go for vaccination again. But it was an exhausting experience, but it's possible.
But that's assuming that you identify it beforehand.
Yeah.
Okay?
Yeah.
That's strategy one is if you identify that patient beforehand, what their response is going to be, then you could do something.
But in the meantime, of course, you have to avoid that you repeat the procedure. So here comes the question, can we use another strategy as long as she is under psychological treatment? These are the children where we, instead of distraction, decide to go for general anesthesia for certain procedures and to change the strategy. And when you change the strategy for these kids, you don't activate that automatic cycle, and for a while they learn, they take good care from me, you keep the trust, and for a while you do something exceptional. But of course, if you go on forcing them down for the same treatment while they're with a psychologist, that's not going to work. That needs teamwork.
Now, that with several children to take them through under, sedation.
Yeah.
And then they have taken a step forward. But this girl in particular, she wants to do this, doesn't want sedation, and it takes from 5 until 20 minutes, and every time after it was, okay, wasn't that bad? It will be okay next time.
Yeah, it's that moment. And there are also children, by the way. We have children in our population who say, okay, I will control myself, but I need to scream. And I scream, and we scream with her. And so when you hear us from another room saying, wow, what kind of pig are they killing there? But and afterwards, she's happy, and they come back the next time full of trust. It's about trust. So if they come back and they have all the signs that they trust you, you're on the right way. So it's individualized care and trying to do the best for that particular child.
I think you also should talk about Plan B and the whole notion of...
Again?
You should also talk about Plan B and the notion of having a Plan B in those situations.
Oh, yeah. Yes, there's another question there?
Could this child she's talking about, could you give this child or I mean, could you, are you doing that?
Yeah. That's an excellent question. I have time up to breakfast tomorrow morning. Is that okay? No. It's could it be helpful? I think in a girl like this, how old is she? 7. It could be a part of the strategy to discuss with her, shall we try some relaxation drug for you? And then I would try it without doing the procedure, but just having her the opportunity to practice. And if you would think that nitrous oxide would be an option, we have done nitrous oxide sedations without a procedure, just to practice and learn and to create confidence. Even under nitrous or midazolam, this freaking out system might still be active.
Yeah.
But just one thing about this midazolam. Imagine what midazolam is doing. It's taking away your control. What this girl needs? Control. And here's the big challenge. If the patient is open for a relaxing drug, like this 3-year-old who doesn't understand the whole procedure but just needs some add-on for relaxation, midazolam might be a great drug. They fall asleep, they become drunk, they're happy, and in the meantime you do a little bit, you sing a song and you do the puncture, and they wake up again and they go home and they have a great experience. But in this child with a programmed stress, if you take away their control, midazolam could become a rape drug in their feeling. So I would not choose those drugs. I think I would choose a sedation strategy that they don't feel anything, keep the comfort, work with the psychologist, and then see what happens next.
The other thing is very important, I think, in every procedure you're going to do to have a Plan B.
Yeah.
Beforehand.
Yeah.
So then you're not in this cycle where you're trying things that are not going to work and you're getting frustrated and tormented, the child is getting more traumatic. Yeah, so.
Yeah. Plan B is so crucial.
Plan B.
Yeah.
Very
And Plan B.
Is the procedure, at that moment, is the procedure urgent? Does it have to be done now? Can we postpone it and do some other things in the meantime? Can we, there's other, do we need to stop? They will do sedation and et cetera. Yeah.
Plan B is crucial, and very often Plan B is beyond your own control. Like you're working with nitrous oxide, but there are certain kids that nitrous oxide will not be sufficient.
Yeah.
Where you actually decided before you start, or that you start and you say it's not going to work. So you need a Plan B, and that Plan B can be beyond your own control. That you need collaborate. That's why this field is an interdisciplinary field. You need a good collaboration with the anesthesiologist who knows, I've tried nitrous in this child, but I would like you to do now the next step, and that everybody agrees that that next step is organized in the system, that's available. Yes.
And here we should say also, we're very good at, if a child has, we identify an allergy that a child has. That goes down in the medical record, so the next person to deal with the child sees that information. We should be doing the same thing with these type of children. With the children who, in a situation, they're very traumatized, that should go the record. Child responded very well to this in a strategy, was anxious, responded very well to this, that should go into the record. Yeah. So there's consistency, and that's passed along.
That's absolutely, it's a crucial thing. And even more, imagine that you treat this girl that you've seen on the lap of her father, and you were there as a nurse, and you write down in the file, this girl is best punctured in her right hand. She always has her doll with her with the stickers on there. She's sitting on her father's lap, and they're looking in this book. Do you work every day from morning to night? Probably not. So the next time the girl might come to you. If you read in the file that this girl always has her doll with her with the stickers on it, and this book, etc. When you approach the girl, wow, you brought your doll with you again. And So you figure out already the same scenario that was written down. Predictability, consistency. So that's a matter of organization. So your patient files could help you to make it a consistent thing. Otherwise, what you invented as a brilliant idea and she doesn't take it over, she might damage the trust you built, or vice versa. That's how delicate it is. Yeah. We can go on. My trousers are now dry, so maybe as a final, just final slide, a final slide. This is the model we use. And this is not a protocol. This is the model we use. And as you can see, we discussed pain killing. We discussed psychological strategies. That's the whole thing about avoiding fear and focus, you remember? And then in the middle of the model is personalize the procedure. That girl that you are treating for a simple blood sampling is a completely different child than any child that comes in and has never been traumatized before. So personalize the procedure. What does this procedure mean to this child? That's a crucial question. And never say that something is minor or simple, or that it doesn't hurt. You don't know. Okay, let's agree that we will never decide anymore whether a procedure is painful for someone else. Okay. My course in obstetrics was given by a male professor in obstetrics when I was a medical student, and he announced that delivery was not a very painful procedure. He had no personal experience whatsoever. So it's proven, by the way, that when we see painful procedures in children, that we don't see the same thing like parents see. We deactivate our emotional parts of our brain to be able to work. We don't see the pain. We don't see the fear. So we are blind for that. That's scientifically proven. So that's why we have to purposefully ask ourselves, what does this procedure mean to this child? Then there is the P of prevention. Is this procedure needed? For example, imagine that the girl comes after 6 months of psychological treatment, she comes for her next blood sampling, and you see she might not be ready. Can we wait another 3 months with the blood sampling? Oh no, it's not in the protocol. Let's call the specialist. What would happen if this child gets her blood sampling in 3 months instead of today? Yeah, okay, because balancing medical interests, psychological interests, and most of the cases we can postpone the procedure. Most of the cases. Child comes in with gastroenteritis, 11 months old, vomiting. What do? Nasogastric tube and oral rehydration. Yes? That's a very painful event for a child. Could we prevent that? Could we relax the mother and ask, especially the mother, ask her to give spoon by spoon the ORS, and when the child vomits, go on spoon by spoon. There's a huge chance that you will not need the nasogastric tube. So, can we think of prevention? Or a child comes in with a severe infectious disease, needs antibiotics for 3 weeks. Can we ask the anesthesiology department, surgery department, to put it in a central venous line for 3 weeks? That prevents a lot of blood sampling and no IV failure for 3 weeks. You see, that's prevention. Prevent procedures. Then the process. Do you remember the picture of the father and the daughter and the child-led specialist? And it looks like nicely designed, but they have been thinking about the process. They have organized that setting that way. And the one who's doing the puncture knew that she had to be there when the distraction was optimal. That's organization. We call it nowadays choreography. I love the word. We are dancing together. Together with the 4 of us, we are going through the procedure. There's the mother, there's the doctor, a nurse, and we are moving with the child. It's dancing. So let's dance. Choreography. It's very important to understand each other's goals when you do that. When you are in the full distraction with a child, and then the doctor comes in and starts explaining why CRP is so important, the magic is gone. So he should keep his mouth. Single voice principle. So these kind of things, practice with each other. Sometimes you need sedation, procedural sedation, not also always. And then finally, and here we come back on learning.
But this is a critical point, because as we've talked about before, it's critical to make the assessment in the child right from the start. Is this child, no matter what I say to the child or what psychological strategies I use, it's not going to work? They need,
I need sedation?
That's a very important assessment right up front. So if you make that accurately, then you save a lot.
What typically happens is that you start without sedation, there is a struggle, and then let's call in the nitrous oxide boys. Don't go on there. If you are sedated while you're frightened, when you're fearful, it's not a good experience. So indeed, it's part of the beginning. And then the final thing is the learning together. Once the meeting is over, when the procedure is over, don't walk away, don't run away. That's the moment to close the meeting, to debrief, to reflect, to say, you did such a great job because. Or if it was not a good job, we can reset. There's a lot to be said for restoration of trust if trust was damaged. But what we usually do when we hurt a child, we all run away. And we leave them with their mother or father. That's the moment where we should take some minutes to restore trust. It's learning. Think about the long-term effect. So we pay a lot of attention in our courses on this, and it takes you 1 or 2 minutes. And then write down in the file, this child needs this blood sampling in this way, then we close it, and then it's written down.
But also there's possibility of, in the first 2, 3, 4 minutes after, give me a second, get there, after a procedure, to reframe that experience for the child before they lay down that traumatic, emotionally traumatic memory. And I'll give you an example, and you can extrapolate from this. There's a procedure that I do in children, adults, it doesn't matter. Nobody likes this procedure. It's a throat culture, right? There's no human that enjoys getting the back of their throat. It's a noxious experience. So I go in to see a child, and let's say this child is 5, 6, 7, doesn't matter what their age, 4, and I have a popsicle behind my back, and I have them open their mouth, stick out their tongue. Let me show you how long my tongue is. Let's see how long your tongue is. Whatever you do to do that. Now, the moment I do that, that's a noxious experience. The child grimaces. And immediately take the popsicle. I have a purple popsicle. Can you take 3 licks but not 2? Can you take 3 licks but not 2? Now the child is confused, so already shifting their
curiosity.
Attention. So I'm purposely confusing the child, and I have that task for them. So I give that to them. They take 3 licks. Now can you take 4 licks but not 1? 4 licks but not 1. We do that a couple times, and then it's done. And whatever that grimace was, that's gone. And what is left is this. So I think you can extrapolate from, and there seems to be there's like plasticity there in that couple minutes after the noxious stimulus that it can be reframed in a certain way. So that I think of it also as part not only of the learning part you're talking about in the post-procedural, but there's things that you can do that will reframe that to prevent laying down an emotionally traumatic memory. And I do want to finally say about this is both Piet and I know that the way things are is children can be afraid, children can experience pain and discomfort. That's just part of life. That happens. What our concern is that the child does not lay down an emotionally traumatic memory from their experience, right? Because all of us have seen these kids, half the kids we put IVs in, they scream and and 5 minutes later they're running around the room, happy, playing, doing it, right? So I think part of the problem is we just don't know. We don't know how to identify those children who in 1 in 1,000 or whatever will be traumatized by an experience that most other children would be able to tolerate. And so we try to do all these things to avoid that. So just wanted to say that piece.
By the way, that technique of the popsicle, we used it a lot in the time of COVID. You remember that all these kids need these nasal swabs that they didn't like at all. So we had this strategy. We had a swab in the hand. The child was given the popsicle. Okay, we do 3 times in the nose, 1, 2, 3, and immediately after you do 3 licks at the. Let's see who can do it the fastest way. Chuck, and it worked amazingly. It cost just the price of the sample increased a little bit because that popsicle cost 0.3 euro or something like that. It's,
I think we are afraid of giving sugar to kids. With the get of sugar, parents give them sugar, but if a bad professional will give them popsicle with the salt.
Yeah, that's sometimes we create our own problems, don't we? Yeah. Okay, that's the PROSA conference in September. We have some of you have been there already, I think. We have changed the whole program. Instead of many lectures, we have now only 6 lectures, and the rest is all workshops. And you can compose your own journey. So you can go to the program and say, if you go as a team, for example, you can decide, let's go with one part of the team to that workshop and others to the other, and then bring it together as a hospital or department. So it's much more flexible. Just go to, for those who are interested in sedation, there's a whole parallel sedation program of 2 days when you want to learn everything about sedation. And we have on the Wednesday, you see it's on Thursday and Friday, 10 and 11, and on the Wednesday, September 9th, we have pre-conference activities, and we present 2 master classes. And one master class is by Baruch, where he actually will, the whole model, the cycle, the circle you've seen, and this fear to trust axis, we have now explained it in a rather rapid way, but then it will be like a 3-hour workshop with videos, etc., where you dive into depth into the whole model and can practice, etc. And there's another masterclass by Stefan Friedrichsdorf. Maybe you know the guy, he's from San Francisco, and he has created a program which is called the Comfort Promise. And that's actually how all these dreams we have, how can you make that a common policy in your whole hospital? How can you actually make it a common endeavor that everybody supports? And so he's giving another masterclass on this big challenge. How can we make it one big vision together?
And you should also say, we didn't get a chance, someone here asked about autistic.
Oh, yeah.
Yeah, there's a section.
Yes, absolutely. We have, I mentioned that there are 6 lectures. One of them is by Mary Doherty. Mary Doherty is an anesthesiologist from Dublin, and she has a specialization in sedation, anxiety in children with autism. And she has designed a model how you could actually frame your work when you deal with autism. And she will give a lecture, and together with a pediatrician who is a patient with autism himself, they will give a workshop on dealing with autism, a 90-minute workshop on that topic. It's a complex topic, but we understand more and more how it could work. So, and we could also send the papers that she has written to you, or that you can share with each other as a kind of reading.
Yeah.
But,
and Cyril's work.
And then Cyril will also speak about. Cyril is one of our colleagues from Geneva. And he has this great program of children with autism that need, for example, vaccinations or blood analysis. And they combine dexmedetomidine with nitrous oxide. But the dexmedetomidine is actually to make them asleep, so that actually they accept the mask for the nitrous oxide, and then together with the amla they are punctured. But before they accept the nasal dexmedetomidine, they practice at home. Not with real Dexmed, but with the acceptation of the intranasal device.
Who the mother is giving to the patient.
Yeah.
And then when they come to, and they practice with the mask at home.
Yeah.
And then so they're completely desensitized, familiar, predictable. And then when they come in, the mother gives the dexmedetomidine and puts on the nitrous.
These are children with severe autism.
Severe autism.
That actually,
who they have to, these kids.
Yeah.
These are very severe kids who we don't deal with well in the system. We often they're lost because they don't want to come into. It's impossible to even get them into the hospital. They're so anxious and
that work is published as
fall
well.
through the cracks in the system, and we try to bunch all this stuff together.
And that protocol has been published. It's a paper.
So there's there's the whole protocol approach, the share. What's it called? That framework.
By Mary Doherty, her autism framework, or
there's an acronym for that.
I forgot it.
Yeah.
And the final topic is neonates, so newborns, a big challenge. And so we have invited people from the NIDCAP community in Sweden who will present their work and how to do a procedure while singing with a baby and a mother on their lap and doing a blood sampling or an eye examination. It's amazing what is possible nowadays without sedation in these young children. So there are some intriguing topics we brought in, so a lot of practical stuff. And,
I do want to say one thing about just this about singing. We've done 2 programs in Denmark, one in South Denmark, one in Copenhagen. And apparently, and maybe you want to try this in Iceland, the Danes have a tradition where they start every conference with the whole audience singing.
Do you do that in Iceland? I thought it was a tradition to end a meeting with singing. That's what was told to us. We have great expectations now.
Yes.
I think we are. You're Danish.
Yes, we did it in school.
You did it in school.
In the morning.
In the morning, singing. Yeah, it was.
How wonderful!
Yeah, wonderful.
Yeah.
Okay.
We loved it. It was great. We didn't have it started. Okay, we were about to start, and they said, "No, wait, we're going to sing." And
so it's 6 o'clock. We can just go on as you see, but I think thank you for your being here and being so interactive with us. That's what it was a pleasure to be here again.
Yes, thank you.